the design that both encourages the use of value-based, I mean, the services you really need to make sure a senior wouldn't skip health care that they really need. How would you design, as we simplify it and unify, how would you design it to make sure that we're encouraging seniors into those essential value services? What would be the key ingredient?
The nice thing about the three witnesses, we all agree that the discussion should go beyond how much we spend on Medicare, but instead how well. And this concept of clinical nuance, as you mentioned, some good services which are highly recommended by professional societies, HEDIS, other organizations, are those that we would immediately identify and have already done in hundreds of organizations in the private sector to say these services are so important that patients should not pay a substantial amount of pocket for them. As Mr. McDermott mentioned, that is currently the case for preventive services in most public and private plans, and we are in fact trying to extend these services for common chronic diseases, for doctor visits, diagnostics, tests, and drugs that have been identified by professional societies as the things that should be performed. And that would be the basic premise for us to move forward on the carrot side or the high-value side of value-based insurance design.
On a scale of 1 to 10, how difficult is it to, now that what we know today versus a half century ago?
Given that almost all of your expenditures in Medicare and chronic diseases, and most of those chronic diseases can be lumped into about 14 of them, and the fact that there are guidelines that are evidence-based in most of those conditions, I would say that that's fairly straightforward.
Great.